So I had the opportunity to present the results of Empower 131. What this study was, it was a 3-arm study evaluating patients with squamous non-small cell lung cancer. It was a 1,000-patient study where patients were randomized 1:1:1 across 3 arms. Arm A evaluating carboplatin and paclitaxel with atezolizumab, immuno-oncologic agent. Arm B, carboplatin, nab-paclitaxel, and atezolizumab. And then Arm C, which was a control arm, carboplatin and nab-paclitaxel.
Any variation within the patients to each of those groups?
The patient populations were very well balanced across all the predetermined subgroups that oftentimes lead to changes in overall survival patterns based independent of treatments. So it was well balanced across both the 2 groups that we were analyzing.
And when it came to treatment tolerability, was there any variation?
We saw typical toxicities that we've seen historically with the immuno-oncologic agents, but in this particular study we did not see any added toxicities when atezolizumab was added on to chemotherapy. So typical toxicities that we're seeing were hypothyroidism, colitis, but not at a higher rate than we've seen historically with the use of these agents.
When it came to the endpoints, could you tell us about the trials and if they were met?
Right, so the primary endpoints in this particular study were investigator-assessed progression-free survival, as well as overall survival, and then secondary endpoints were progression-free survival and overall survival in the PD-L1 subgroups, as well as duration of response and safety profile. And in this particular trial, the primary endpoint of investigator-assessed progression-free survival was met with a doubling of the progression-free survival. Control group of 12% progression-free survival increased to 24.7% at 12 months. And some of the secondary endpoints that were exciting, secondary endpoints that were met, was evaluating the duration of response, which was doubled in the intent to treat population, as well as in the PD-L1 high and PD-L1 low populations. And so very exciting data in the sense that we are starting to see greater response rates as well in those patients that have that PD-L1 high expression, with a doubling of that response rate going from 30 to 60% in that patient subgroup.
And there were some also concern about the effect of chemotherapy on just knocking down the immune system, but that was found to not be a challenge?
While we did see some instances of neutropenia occurring, it did not appear to be a substantial increase in those patients that were receiving atezolizumab in combination with the cytotoxic chemotherapy.
I suppose then the big question is, where do we take this data next?
So at this point, right now in this study, we're not seeing differences in overall survival in the intent to treat population. I think that the take-home message at this point is, yes, we have further assessment to do of overall survival as the data matures, as well as evaluating those subgroup populations of PD-L1, PD-L low subpopulations in this study.